Welcome to my podcast. Today, I'm going to talk you through another one of the important topics that you could face in the clinical setting. So basically, the patient will come to you and says that, "Hey, doctor, I'm having burning in my wee, and I don't know what to do." So after we always agreed that you need to double check the patient name, date of birth, and introduce yourself. So I will ask, how long ago did you start those symptoms? Can you clarify what symptom do you have? And if it's a young lady, sexually active, you will ask about the sexual history and if there is any history of sexual transmitted disease or infection. And you will ask if if her partner or husband have any symptom similar to hers. And if it's a different case scenario, if it's a mom brought in her baby or her child and complaining that they started all of a sudden to wet their bed after they started to control, or if they have unexplained symptoms that doesn't make sense, or if they presented with kind of pulling in their tummy, or if they have any medical condition that could be existed. So it's a different case scenario that I'm going to tell about while I'm talking about this podcast. So UTI, urinary tract infection, it's a common problem encountered. Basically, it affects all age groups with 50% mostly female who would have like one case episode in her lifetime. And I can tell from my experience when I was studying medicine the second year, I had all of a sudden been feverish. I couldn't wee, and I couldn't. It was really a dreadful situation when I remember it. So my mom took me to the hospital, who they admit me, and they wanted to catheterize basically me, and my mom declined. And I was examined by one of the doctors because most of the doctors, they were like saying different things. However, he examined me and he said that I had a complication to my recurrent tonsillitis, which could have affected the situation. And I remember that dreadful moment of my life, which mandated later on to have my tonsillectomy in order to not develop those kind of symptoms anymore. And yes, I did that. So, in short, when we need to define UTI, it's basically like 3 episodes or more in a 12-month defined period of time, or it could be like 2 or more within 6 months, according to Butter 2015. So in female, mostly it's due to the bacteria ascending from the urethra, because we know that urethra in female is quite short. It's around 4 centimeters. And this made her more prone to UTI, and basically there's like two lifetime that a lady can encounter that. So it's one of that, it's in the adolescent, and one in the menopause stage. So in the hospital setting, a catheter can be associated with UTI due to nosocomial infection, which could cause gram-negative sepsis, and that's, of course, a case mandate attention. I had written a paper which has been published. However, I'm going to put it as a link during this podcast to think about something called purple urine syndrome, which is a different entity and can be challenging sometimes if you're not aware of this kind of condition, and could be considered as a differential diagnosis as well once you saw the urine as such. So if there is like more than 10 colony to the square of 5, this can be deemed and should be deemed basically as a diagnostic of UTI. However, in certain situation, it could be asymptomatic bacteriuria where there's a presence of bacteria without basically any symptom from the patient. And the UTI can be divided into two, either it's the lower or the upper UTI, which means that the infection basically either affected the lower part, which is the bladder and the urethra, or the entire tract. And this can be, of course, warrant attention. Cystitis, as we all know, it's basically inflammation of the bladder, and it could lead to dysuria, which could be the patient will have frequency and urgency with the burning wee. So there's this idea because they say that the UTI is on the rise. There's the idea because of the antibiotic, most of the antibiotics that we know for the UTIs started to become resistant. So there's kind of products which a nice guideline recommended, and I will tell about them, like for instance, cranberry product, supplement, those kind of stuff, which I will hint about at the end of this podcast. And as I mentioned, females usually they have their UTI peaks in two periods of time of their lifetime. One in the adolescent and one in the menopause. The menopause, we know, it's mostly associated to vaginal atrophy, loss of the commensal, which is the lactobacillus acid microenvironment due to the estrogen depleted state. And according to the NICE guideline, 3 days course of oral antibiotic is enough in uncomplicated lower UTI, with encouraging for the hydration of the patient. And however, comparing to the EU or European Association of the Urology, they are recommending 5 days course due to perceived risk of developing bacterial resistance according to Bankett 2024. So they stress about drinking plenty of water, avoid tea and coffee, alcohol, and citric drinks as they can cause bladder irritation, and evidence lately shown that hydration prevent recurrent UTI in those people who are more prone to UTI, according to Young and Foley 2020. So if you suspect UTI, and if it was like manifested with fever, low pain, in that condition you need to think about upper UTI, and of course after examining the patient you can feel the loin tenderness. And in that condition, a 14 days course of antibiotics is required to treat the situation. However, in those ladies who are presenting with recurrent UTI, you need to ask some questions in order to know if there is any predisposition, like, for instance, if the lady is sexually active and has been with her partner. So you need to ask about postcoital UTI, which could be high. And children, you need to ask about, for instance, constipation and diabetes mellitus. Also, in ladies, you need to ask about if there is impaired emptying, like in postmenopause, or if there is poor fluid intake or atrophic vaginitis if the lady complains of dryness. So as the antibiotic resistance is on the rise, as I mentioned, so there is a recommendation for non-antibiotic options, which are advised and advocated nowadays, like cranberry supplement, topical estrogen replacement, intravesical treatment, and immunomodulator vaccine. And if a lady is pregnant, for instance, and she has UTI, you need, of course, to avoid nitrofurantoin, as we all know, at the last trimester. But however, it can be used in the first two. And we know that penicillin and cephalosporin is safe in the pregnancy, so they don't have any issue in giving that. And of course, we know that brim should be avoided in the first trimester, an aminoglycoside, because it's teratogenic and can cause ototoxicity, as well as quinolone, because they can cause arthropathy and fetal cartilage damage. In the children, it's a complete case scenario, so can be tricky as well. So usually the child will present with vague abdominal pain. They might lose their appetite. They might be feverish. They could be vomiting. They could be having like incontinence or secondary incontinence after they were dry. So in that condition, you need to, of course, think thoroughly and send for ultrasound. And if the child has UTI, you need to think also about renal tract abnormality. And in such a situation, you need to exclude some associated condition like chronic constipation, vulvar irritation, and thread worms. All of that can cause same symptoms. So most of the common implicated microorganisms in the lower UTI are, as we all know, E. coli, Escherichia coli, Pseudomonas ambrotius. However, if it was hematogenous spread to the upper part of the kidney, urinary tract, and it causes upper urinary tract UTI. So most of the microorganism implicated in that condition is staph. And of course, this kind of condition is really serious that you need to treat thoroughly and maybe needs admission. So the first antibiotic can be tried empirically in uncomplicated lower UTI. It's mostly nitrofurantoin. And if you send, for instance, MSU, which is the midstream urine, in certain situations it could be sterile, so you need to make sure that the patient didn't start antibiotic prior to that. Or if they have like renal tract calculus or stone, or if they have infection with gonorrhea. So that's one of the things you need to consider, those kind of situation, because can be tricky sometimes, and it could lead basically to confusion when you want to treat the patient and address their symptom. And of course, if it's a lady or a man, you will ask those kind of questions, and then you will ask them if they have any thoughts about what might be the reason for their issue. And you will ask also, what are you hoping from our consultation today? And then, of course, you will ask if they have any comorbid situation, if there is any underlying medical condition that warrant attention. Also ask about the family history, if there is any similar attack. It could be hereditary or something. And of course, don't forget about asking the medication, if they are taking any medication at all. Say, for instance, patient might take non-steroidal anti-inflammatory in the long run for whatever reason. They might end up with some complication as well. Or if they have any OTC medication that they're taking by themselves, thinking that this will help or being recommended by someone. And of course, you need to ask about their lifestyle, what they are doing, work-wise, if they are fit, and their social status as well. If they are supported, stuff like that. And then you will tell them that I would like now to have a quick look, if that's okay with you. And if there is a need for a chaperone, you need to mention that. And then you will tell brief the patient what's the situation and what you think of the situation. And if you need to send for some blood investigation or urine, you need to explain how to collect the urine in a sterile manner. And of course, if there is any need for any medication, you will discuss that with your patient and see how they think about that and what's their thought. And then, of course, you need, of course, always to red flag the patient and state if situation getting any worse and if not feeling yourself or not improved, you need to come back to us again or go to the emergency. So I hope by that I covered the UTI and the nice guideline around this area, and I'll put the link for the purple urine syndrome. And if you have any issue or any feedbacks, you can feedback to me and I will get back to you. Thank you.